So it's more behavior than biological factors. Men will socialize usually in very crowded places. Like I said, they tend to go to places that, you can imagine if today you have a political rally, the bulk of people who will be in that crowd will be men. If you've got a game of football happening between two big teams, the bulk of people, the majority of people who will be crowded in that stadium will be men. If you go to pubs, bars and drinking places, the larger number of people who will be in those places will be men. So those behavioral things are the ones that are probably driving higher rates of TB infection in males than in females. We haven't identified at this moment in time specific factors that make one gets more TB, increase the risk of getting TB in the lung versus getting TB outside the lung. We don't know why that is so. We don't know why some people don't get TB of the lung and they get TB of the brain, or TB of the bone, or TB of the liver, or TB of the intestine, and so on and so forth. We really do not know at this moment in time. That would be a nice research study to try and do and unravel some of those unknowns in the TB field. So extrapulmonary TB basically means TB outside the lung, and TB textbooks will tell you that every organ of the body can be affected except maybe nails and hair. Those are the only two organs in the body that are not affected by TB. Now, how does the doctor know that you have TB of some organ? It begins with the symptoms. Doctors are trained, or other clinicians are trained to be able to identify where the problem is. If you walk into a doctor's office and your problem is headache, and your problem is convulsions, you are having fits, or your problem is you have you can't move a certain part of the body, the doctor will, and maybe you have fevers and you're sweating and you're losing weight, the doctors will want to see how the brain is, and they'll probably do a scan. That could be a CT scan or an MRI scan, whatever scan they do. And that may show characteristic features in the brain that tells them that this is brain TB. Now, brain TB is difficult to diagnose. Usually it's diagnosed not by confirming that there is TB germs in the brain, because it's difficult to sample the brain easily. It would be very complicated to sample everyone with brain TB. But at least based on the symptoms and the characteristic features on the CT scan or MRI scan, the doctor will know this person probably has TB of the brain. And it's the same thing with TB of the bone. It is the same story with TB of the liver, although structures like the liver are much more easily accessible to doctors. They can sample the liver. Urinary TB is the same kind of thing. But urinary TB or genital urinary TB may be a little easier to pick out, because you can check urine, and you can do all sorts of diagnostic tests that help to identify TB in those parts of the world. So in those parts of the body. So in essence, it all depends on how that individual presents and how easy it is to obtain a sample from the part of the lung that has been affected by TB. In some parts it will be very difficult, and therefore the treatment for TB is based on the doctor's best knowledge of the disease, and in some situation attempts can be made to sample the organ that's been affected, and then take those samples to the laboratory to again test for TB, the way you would test sputum samples, for example. So extrapulmonary TB outside the lung is a difficult clinical diagnosis, and there's a tendency for people who have extrapulmonary TB to have their diagnosis delayed. It happens all over the world. It's not a Kenyan thing. This is because the symptoms and signs of TB outside the lung are very non-specific. So you can get fevers for all sorts of reasons. You can lose weight for all sorts of reasons. And if you're presenting, if your first call is a health facility like a dispensary or a health center where you don't have high caliber clinicians to really dissect out what the problems might be, by the time you get to places where there's clinical capacity to be able to think through the diagnosis and consider TB and do the appropriate tests and what have you, it may be quite a long while. This happens all over the place. However, the TB control program in this country and others have made very, very good efforts to try and train and support healthcare workers at all levels, including at the community level, to be able to know when to suspect TB. The focus has been mainly on lung TB or pulmonary TB, and that's why there is a little bit of challenges with diagnosing extrapulmonary TB. However, healthcare workers are being trained to identify people who have TB, irrespective of where that TB is happening. But like I said, the diagnostic capacity is difficult. If I present in a health center that cannot do brain scan or MRI, I am referred to the next level and the next level, and then I have problems. Remember, TB affects mostly poor people, and to be able to move from a dispensary to a level 4 or 5 hospital where my TB will be diagnosed may be difficult. Finding the money and what have you to be able to transport myself to the place where a diagnostic capacity can happen. Even when I get to those places, in this country, unfortunately, one has to pay for the CT scan, one has to pay for the MRI scan. National Health Insurance Fund, which is changing to something else, doesn't cover, and not all of us are registered with it, so on. And so there are many problems. And I think the overall effect of that is that there's a delay in diagnosing extrapulmonary TB. But it's a global phenomenon, it's not a phenomenon peculiar to Kenya. There used to be, but I think now technology has advanced, knowledge has advanced, there's lots of research that has been done. By and large, most people with TB and other so-called comorbidities, HIV, diabetes, chronic kidney disease, can be managed successfully with the current level of, with the current tools that are available. So one shouldn't worry that they have TB and HIV and what would happen to them. Yes, the considerations must be manage both conditions, and depending on the condition that you're dealing with, prioritize which one you want to start with, then go on to the next one, or manage both at the same time. There are many permutations here, and the basic thing is the management of TB and comorbidities must be so-called patient-centered. You need to know what the best thing to do is for that particular individual. And again, healthcare workers in this country and in other parts of the world have been trained to be able to know these things and to be able to offer treatment that is appropriate for people with TB alone or TB with other diseases. So during the evaluation of people who have TB, that evaluation should be holistic. People should know everything about me as a person who is being treated for TB. How old am I? How young am I? Where do I work? Do I smoke? Do I drink alcohol? Do I have food? Don't I have food? These things eventually influence treatment outcomes. And I should have a treatment plan or a care plan. This is not just treatment, it's a care plan that takes into account all those issues. Because tuberculosis treatment, unfortunately, is lengthy. Bare minimum 4 months. if with the currently available tools all over the world, bare minimum is 4 months. Most people are treated for 6 months. Some are treated even for longer if they have drug-resistant TB. And therefore, that care plan must take into account every little social, mental, or comorbidities or core diseases that are with that individual, ability to travel from one point to another to come and be supported, whether in fact I am willing or not willing to have a community healthcare worker to come to my house and to support me. That's called holistic care, and it is a very important part of managing anyone with chronic disease. No one should be given blanket care for everyone. Human beings are very different, and therefore every human being should be evaluated for their peculiar circumstances and be provided a care plan that is fit for their purpose. Now, this is where sometimes the challenges are in terms of programming, public health programming, because you want to do this for people, but there may be limited capacity from the healthcare system to be able to offer that. But there has to be a constant struggle to offer comprehensive or holistic care to people who suffer TB. There are many things that are happening. The research world is abuzz with innovations and work that is being done to try and improve TB diagnostics. Sputum is not a very good tool. A lot of people are not able to provide it, for example. A lot of children find it difficult to provide sputum for TB testing. So people are looking at all sorts of things, including what we call tongue swabs. You swab the tongue and take that to the laboratory and see whether that is going to give you a TB diagnosis. People are looking at breath. You analyze the breath and see whether that breath has a peculiar, they are called volatile organic compounds, VOX, peculiar profiles of these so-called volatile organic compounds that then can tell you that probably inside there, this fellow has TB. People are looking at urine samples as an easier sample to obtain than sputum. People are looking at blood and looking at what we call gene signatures and so on and so forth. So there's a lot of work being done to identify better tools to be able to diagnose TB, including tools that will be useful at the home setting. Today, if I want to know if I am diabetic, I can buy my glucometer, go home, test myself for TB, and if I know what levels mean diabetes, I can tell I'm a diabetic and walk to the healthcare facility and say, Doc, I'm a diabetic, can you treat me? Today, if I want to know if I'm HIV infected, I can buy my kits and test myself at home. That's where we want to take TB. We want to take TB to the same level where people can actually do self-testing at home. I think if you ask me that question, the most important thing is that we should mobilize resources to fight this TB. And I personally believe that there are certain diseases that we shouldn't be happy that we have them. These are diseases of shame. Tuberculosis is one of those. Cholera is one of those. Typhoid is one of those. These are diseases that we should have gotten rid of many years ago, because you can't go to anywhere in the world and say we have a big problem of TB and be proud that you have a big problem of TB, or go and say you have a big problem of cholera. If you provide people with water, piped water, for example, and sanitation, you get rid of cholera and typhoid. It's the same story with TB. We can test very many people. We can make sure that everyone who is vulnerable for TB is tested for TB. If they do have TB, they are treated for it. If they have TB infection, they are treated for it. And if we did that regularly and consistently, in another 10 or so years, we could have brought this TB down by more than half of the problem right now, if not more. So we can do it, but to be able to do that, we need political commitment, and we need to mobilize the resources to be able to do that. Unfortunately for this country, the bulk of the money that we are using for the operations of our TB program, yes, I know we are spending our own money to make sure our TB program officers have salaries, they have water in their offices, they have electricity and so on and so forth. But we are not paying for TB testing, and we have not been paying very well for TB medication. And we need to be able to pay fully for our TB program, to train our healthcare workers, to supervise our healthcare workers, to make sure that the diagnostics are there and the treatment is there. So we need to mobilize sufficient resources to be able to do that. Now, TB does not just happen in isolation. It happens in combination with other things, social factors and other diseases, and we need to have a comprehensive approach to deal with the problem of TB. And that means political commitment, additional resources, and these resources should be domestic as much as they can be. So, like I said, tuberculosis affects both male and females. The consequences are poor for, or rather the consequences of TB are bad for both men and women. But think about that woman. A woman who has TB means the family is all in, from a societal and social point of view, they can't take care of their families, okay? So even if the man in the house, suppose this is a married woman, even if the man in the house provides the food and what have you, but they are very basic things that women tend to do in our societies. They take care of the homes, they're the home builders. It means if the woman is unwell, there's a major problem in terms of how that home runs, okay? And that has consequences. It has got consequences on the man himself, and has got consequences on the woman directly, and has consequences on children and neighbors and everyone else. Two, there are certain forms of TB. So if the woman develops complications of TB and cannot take care of themselves and lifelong, that woman will probably suffer higher degrees of stigma and discrimination. So because they can't take care of themselves, they have a big risk of being TB. There's a big risk of that TB leading to infertility. These are big issues. So women are massively affected by the TB problem. And that's why for us, it is not a question of saying men versus women. It is ensuring that we have a comprehensive package of care for people with TB, irrespective of whether they are men or women, and taking care of all the consequences that can happen in people who have TB, whether they are men or women. Yeah, I mean, the stigma and discrimination and all those things that affect people who have chronic illness, and especially TB, is huge amount of stigma and discrimination, and the provision of care that is not rights-based. You know, I need to know that I have a right to health, I have a right to medicines, I have a right to be treated decently by healthcare workers, and so on and so forth. And these things we know, but a lot of people in the world and a lot of people in TB program don't practice this kind of things. So rights to information, rights to good quality care, rights to receive care in an environment that does not increase my risk of getting other things. All those things are important. So the Global Fund has been a big mover, together with the Stop TB Partnership, has been a big mover of a rights-based approach, and I would actually also add WHO there. They've been big movers of a rights-based approach to the provision of TB care and prevention services. And we shouldn't take these things for granted. There are huge problems of human rights barriers to accessing care and for TB and other services related to the TB problem. So yes, I am fully supportive of a rights-based approach to the provision of services for TB. So I am Jeremiah Chakaya. I am a medical doctor by profession, and I'm a pulmonologist. Pulmonology means I am specialized in lung diseases, and among those lung diseases is tuberculosis. We consider tuberculosis a pulmonary disease mainly, and that's what I do. Tuberculosis is a very old disease, or rather we have known as humans. We have lived and known tuberculosis for very many years, and it has been and continues to kill a lot of people in the world. Currently, in 2022, for example, the World Health Organization estimated that more than 10.6 million people developed TB worldwide. And tuberculosis was responsible for about 1.3 million deaths globally. So it is a problem that has been with us for a long time, continues to be with us, and therefore it's important to have this conversation. Tuberculosis affects anyone and everyone. There is no human being who can say that they are immune to TB infection and TB disease. However, there are certain groups of people that for various reasons have a higher risk of being infected with TB and having the TB progress to disease. And if it's not treated, having a higher risk of dying from tuberculosis. So it is the enormity of the problem that makes it important that we have conversations about TB. So you can divide vulnerability to TB into two groups. There are those who are socially vulnerable to TB, and these are usually people who are poor and who are living in situations that are socially deprived situations. So the poor globally have an increased risk of TB. These include people living in, for example, urban slums. If you're talking about Nairobi, for example, it'll be people living in Kibera, people living in Mathare, people living in Kawangware, and so on and so forth. And then you have people who live in refugee camps, for example, migrants. These are individuals who are poor, and because of that poverty, they are living in human conditions, that are, or rather in conditions that are not healthy, and consequently, they have problems of food insecurity. A lot of people living in those situations will be undernourished or malnourished. They may have poor access to health services, and when they access health services, those health services may be suboptimal or not high quality services. They may be living in poor houses, which are poorly ventilated, very dark inside, so poorly lighted and poorly ventilated. And they are also living in a situation that one could consider as being crowded or overcrowded. So all those factors together makes these individuals socially at risk of developing tuberculosis. Now that's one group. But you also have people who have what we call clinical risk factors for TB. These are individuals who, for some reason, have low immunity. And they may have low immunity because they have, for example, HIV infection, or they are diabetic, or they have chronic kidney disease, or they are being given medicines by their doctors to treat something that lowers, whose treatment lowers immunity. For example, a lot of people in this world, or even in our country here, require sometimes to be given long-term systemic steroids. These are medicines that are used to control inflammation in the body, and if you use those for a very long time, you then are at risk of developing TB because your immunity is low. So therefore, in summary, you can divide people into those that are socially vulnerable. They are vulnerable because of societal factors, and then you have those that are clinically vulnerable because they have something that lowers their immunity and they cannot control TB infection, as it were. Dangerous, yes, dangerous in many ways. When you suffer TB, of course you are sick, and because you're sick, you won't be able to work, so there are social and economic consequences. But also there are physical consequences. You feel awful, you got symptoms, and if you don't get treated, or if there are delays in getting treated, you can even die from the disease. Or you can be treated eventually, you can be identified and treated eventually, but have long-term complications because there were delays in being identified and being placed on treatment. So yes, it is a serious problem. So because it is a serious problem, all of us are urged to be aware of the problem of TB. And if we feel like we could have TB, we need to seek care as quickly as possible. And the most common symptoms of TB include fevers, when people start developing hotness of the body, when people start having drenching night sweats. You go to bed and you start sweating so much that your clothes and your beddings become wet, or if you're losing weight. Those are pointers that something is not right in the body, and that something that is causing a problem could be TB. Now, tuberculosis affects mainly the lung. 85% of people with TB have disease in the lung. That's why the pulmonologists are at the forefront of fighting this disease. But it can also affect other parts of the lung, or other parts of the body. So, because 85% of people with TB have TB of the lung, the most common symptoms, in addition to the fevers and the night sweating and the loss of weight and the fatigue and malaise and all those things that are common with illness, you also get to have lung-specific symptoms, like, for example, coughing out blood, having difficulties in breathing, having chest pain, those kind of things. However, 15% to 20% of people with TB have TB outside the lung. We call it extrapulmonary TB. And for those with extrapulmonary TB, the symptoms will be specific to the part of the body that is affected. So if the brain is affected, very commonly there will be a headache, there can be convulsions. If it is in the intestine, for example, the abdomen may be swollen and painful. If it is in the urinary system, there may be pain on urination, and so on and so forth. It all depends on the system that is affected. So like I said before, 80 to 85% of people with TB in the world have lung TB. But 15 to 20% of people with TB have extrapulmonary TB. And then there's a small group of people who have both. You can actually develop both TB in the lung and TB outside the lung at the same time. So dual pulmonary and extrapulmonary TB. This can happen. Also, when you are treated for TB, or when one is treated for TB, there is, for some people, an increased risk of developing TB again. And you might start off with lung TB and then develop TB in another organ. or you can start with TB in another organ and develop lung TB later on, because the risk of recurrence in those who have been treated for TB before is higher than in people who have never been treated for TB. So if I get treated for TB, I have a slightly higher risk of developing TB again as opposed to somebody who's never had TB. The ideal is healthcare workers need to be very familiar with how TB presents and should take every opportunity to identify people who could have TB. And therefore, when I walk as a person, I walk into a healthcare facility, I should be screened for common diseases, including TB. And therefore, healthcare workers have been trained and are being supported to identify people who may have TB by doing what is called a simple screening system of asking people, are you coughing, do you have a fever, do you know, those kind of things. Where possible, it's really, really important to get chest x-rays done. Chest x-rays are very good at identifying people who need to be tested for TB. As a screening tool, it's a very, very useful tool. It's very, very sensitive. It will pick up those who need to be tested for TB very easily, as it were. And nearly everyone who has TB, of the lung at least, will have an abnormal chest x-ray. Once you've been identified as someone who could have TB, then you need to be tested. And that test usually in our country is a sputum-based test. So you produce a specimen of sputum, makohozi, we call it, and that makohozi then goes to the lab and is subjected to appropriate TB testing. That appropriate TB testing, ideally, in the world should be based on identifying the DNA of the germ that causes TB. We call it in our language molecular testing. So that is the best. That is what should happen. Screened for TB either using symptoms or X-ray, and if you've been identified to have TB using either of those, get TB tested ideally to identify whether your sputum has DNA of the TB germs. And if your sputum has DNA of the TB germs, you should then be treated for TB. The repercussions, there are many repercussions. Again, at the societal level, remember, tuberculosis is an infectious disease. What does this mean? It means that the person with TB, especially TB of the lung, can transmit their TB to other people. They can transmit it when they talk, when they laugh, when they sing, when they sneeze, when they cough, and so on and so forth. Therefore, if a person has TB and they are not identified quickly and they are not placed on treatment quickly, that individual will infect other people. And that's how TB is sustained within the population, as it were, because people are taking long to be identified to have TB. By the time they identify to have TB, they've had a big opportunity to transmit their disease to other people. And we want to stop that transmission by identifying people as early as possible. So that is at the societal level. And then at the individual level, if TB is not identified, it can kill, or it can lead to long-term complications, even after it has been treated. So you are treated for TB, you get cured, but you have in terms of the germ has been removed from the body, so you've killed the germs, but you end up with long-term complications that you live with for the rest of your life. And that is also something that we don't want to happen to people. World over, except in a few countries, men are affected a lot more than women. However, that dichotomy, that difference tends to happen after the pubertal years. So in the early years of life, if you look at children, it may be equal. Same number of children who are male versus same number of children who are female get TB. But when you get to the teenage years, you start seeing a separation with slightly more, or rather significantly more males than females. It is not that females don't get TB, but males get more TB than females. Now, we are not quite sure why that is so. There may be biological factors that are operating in this in the human population that somehow increase the risk of TB in males, although the bulk of it is probably driven by behavior. Males tend to do things that are often not done by women. For example, tobacco smoking, for example, alcohol intake, for example, delays in TB in seeking care because people are working and they have to take care of their families, and so on and so forth. So these factors may be responsible for the significant higher rates of TB in males compared to females. It may be behavioral, but biological factors may also be extremely important in driving those differences.